Joint replacement is without a doubt one of the most successful surgeries in modern medicine. It literally gives people their lives back. But, and it's a big but, when things go wrong, they can go very, very wrong. So, as a clinician, you absolutely have to know what to look for. Today, we're going to break down the most common and critical complications of joint arthroplasty.
All right, so here's our game plan. First, we're going to cover the risks that apply to any joint replacement, doesn't matter if it's a hip or a knee. Then, we'll zoom in on the specific issues you'll see with hips versus knees. We'll even talk about what happens in a true worst-case scenario before we wrap it all up with the key clinical takeaways you need to remember.
So, let's start with the big picture. Why is it so incredibly important to be vigilant after these surgeries? Well, it's because the signs of a really serious complication can often be super subtle, and catching them early makes all the difference for our patients. Look, it's true, the vast majority of patients do incredibly well, but as clinicians, our job is to focus on the exceptions. Understanding that full spectrum of what can go wrong is really the first step in developing that sharp clinical instinct you need for post-op care. Okay, let's get into the nitty-gritty. What are the problems you could see after either a hip or a knee replacement? These are the universal complications, the ones that should always be on your differential diagnoses when a patient shows up with a painful joint. This right here, this is your core differential. Any patient with a painful joint replacement, you run through this list in your head. Is it infection? Is it a fracture? Maybe a neurovascular injury from the surgery itself? Could it be a clot, a DVT or PE? Or is it mechanical failure? This includes aseptic loosening, which is a really key concept. What happens is, over time, microscopic particles from the plastic liner, the polyethylene, wear off. This debris triggers an inflammatory response that causes osteolysis, literally eating away at the bone-implant interface and causing the whole component to loosen up. Okay, so those are the risks that apply to everything. Now, let's get specific. The hip is a ball and socket joint, right? And that unique anatomy creates its own unique set of problems after a replacement. With the hip, it's all about stability. The surgeon's main challenge is to perfectly replicate the patient's anatomy, and I mean specifically the leg length and the soft tissue tension of the abductor muscles around it. If the components are misaligned or that tissue isn't properly balanced, the new hip can become unstable or even dislocate. And if that leg length isn't restored accurately, you better believe patients will notice it immediately. Now let's switch gears and contrast that contained ball and socket of the hip with the knee. A knee is basically a really complex hinge joint, and its stability relies heavily on ligaments and super precise mechanical alignment. This, as you can guess, leads to a completely different set of potential complications. In a knee replacement, success really hinges on three things: getting the alignment right, balancing the ligaments perfectly, and protecting that extensor mechanism, the quads and patellar tendon. If the alignment is off, you get an axis deviation. If the ligaments are too tight or too loose, you get stiffness or instability. And if that extensor mechanism gets damaged during the procedure, the patient simply can't straighten their leg. It's that critical. But what happens when these complications are just severe, or they keep coming back, or you're dealing with something like a deep infection that just will not clear? At that point, we have to talk about the definitive end-stage treatment option. And this is it, arthrodesis, or joint fusion. This is the definition of a salvage procedure. You're making a very difficult trade-off here. You sacrifice all motion at the joint to achieve a stable, pain-free limb. It's an absolute last resort, reserved for those catastrophic failures where a functioning joint replacement is simply no longer possible. Okay, we've covered a ton of information. To pull this all together into a format you can actually use, whether you're on the wards or studying for exams, let's just summarize the key points with a nice, clear framework. This is your clinical framework. For any patient with a painful joint replacement, you systematically consider these four themes. Start with infection, always. Then, you evaluate for mechanical failure. Don't forget the risk of thromboembolic events. And finally, you layer on those joint-specific risks we talked about. This approach ensures you won't miss anything. So, we'll leave you with this one final critical thought to carry with you. A patient comes to you with pain years after a total knee replacement that was previously doing great. What is the one complication you have to rule out first, no matter what? The answer is always infection. A painful joint replacement is infected until proven otherwise. That is the one diagnosis you absolutely cannot afford to miss.